This conference will now be recorded.
Okay, good afternoon. Today's topic is enteric fever. So coming to the introduction, enteric fever is the fever. The word itself, enteric, means intestine. So it is the fever which is caused by infection of the intestine. It is an acute generalized infection of intestinal lymphoid tissues or reticuloendothelial system or gallbladder. So coming to the cases, there are two types of forms which causes enteric fever, the typhoid and the paratyphoid. 90% of the cases are caused by the typhoid and 10% paratyphoid. So coming to the historical background, typhoid means typhus. It is like rickettsial-like. Typhus, smoke or cloudy, and phytos, that is the putrefaction of food as a cause. That is the meaning of enteric. So the organisms, coming to the organism, it is mostly gram-negative, non-acid fast bacilli. There is no capsule for it, and it is a non-sporing forming bacilli. It is a very die-hard organisms, and there are lifelong carriers sometimes. So the types are Salmonella typhi, and coming to the paratyphoid forms, Salmonella paratyphoid A, Salmonella paratyphoid B, and Salmonella paratyphoid C. Three forms are same, A, B, C, and Salmonella typhi. But the main problem with this organism is it is a lifelong carrier, can also be present, so which is a very dangerous thing. So coming to the structure, antigenic structure, we already know that there are OH, BI, and what are all these? These are the forms of enteric fever by which the structure is seen. So if you briefly see the structure, you can see a cell wall, and O form, the O antigen is present on the cell wall. In the O form, the antigen is present on the cell wall, and it is a polysaccharide and heat stable form. Heat stable forms are O forms. And if you see the flagella are there, and H antigen is present on the flagella, then it is a H form. It is a heat labile. And if the VI is present on the VI antigen is present on the surface, it is a virulent form, and it is a heat labile form. These three, OH and VI, are useful in serodiagnosis, that is in the Vidal test to distinguish what is the form causing the enteric fever. We have to see whether is O antigen on the cell wall or H antigen on the flagella, and on the surface VI antigen. So we have already discussed there is a cell wall, and inside there is a cytoplasm, and flagella are there on the outside, and also we can see a nucleus and plasmid, that is the DNA. This is the structure, antigenic structure. And coming to the epidemiology, it occurs exclusively in humans, and spread is by the, already we have discussed, contaminated food, contaminated milk or contaminated water, or from the flies from which the human excreta, the organisms are carried to the food. Poor personal hygiene, if the personal hygiene is not good, poor sanitation, like if there is a compact areas or where they excrete outside, where there are large number of flies and poor sanitation work is there, then they may lead to enteric fevers. Age, it is most common in older children and less in and also young adults, but less than 5 years it is only 10%, and less than 2 years only 2% of the cases contribute to the enteric fever. Gender, there is no difference between the male and female, both male and female are equally affected. So epidemiology or continuation, areas are underdeveloped or poor sanitation or poor areas. Annual occurrence, it occurs throughout the year. There is no specific period, but the peak time is July to August. that is the early rain. Where there is early rains are seen, that is the peak time. And incubation period, it is 1 to 2 weeks, 3 to 60 days. And this is the period where there is dose of inoculation. And infectivity period, see the incubation period might be 1 to 2 weeks usually, or 3 to 60 days, but the infectivity period is very long, greater than 2 to 3 months cases are also seen. And carriers are very less percentage, luckily, because sometimes lifetime carriers might be seen. Only 5% are there of carriers, and they carry up 20 to 50 years, and females are more carrier. So coming to the global distribution, we can see the endemic or hyperendemic module, and second fully black one is the endemo-epidemic mode, or the line one is the sporadic or local outbreak mode. So India also endemic area or hyperendemic mode is seen even in India, and some parts it is endemo and epidemic mode. So what are all the routes of transmission of a typhoid? It might be the patient, or it might be the chronic carrier. Through the dissemination occurs through the stool, vomit, or urine. It can be direct infection. It is very less. It is less than 10%, which will cause typhoid fever, or indirect infections. 90% of them, like from the water, from the food, or from the infected any forms, it might cause the typhoid fever. Indirect infections are much more common than the direct ones. Coming to the pathogenesis of typhoid fever, there is a Salmonella typhi, and when it is ingested, it goes into the lumen. Intraluminal multiplication occurs next, and it goes to the intestine lymphoid tissue. From the lymphoid tissue, it is disseminated and enters the bloodstream. From the bloodstream, it directly can infect the liver, spleen, or it also can infect the skin, bones, and central nervous system. From the liver and spleen, it can multiply several times, and it can reinfect the blood alimentary tract or excreted through stools. And from the liver and spleen also, it can go even to the and other systems, like release of endotoxins occurs, leading to toxemia and damage other systems, like example central nervous system. So mostly by ingestion route, we can remember simply like multiplication occurs intraluminal and intestine lymphoid tissues. Already we know what a PAS patches, and to the bloodstream, from bloodstream direct to liver, spleen, or other systems like CNS, skin, and bones. From liver and spleen, release toxemia, damage the CNS, or multiply there itself, reinfect the bloodstream again or alimentary tract, and it is excreted in the stool. So intestinal lesions, we know typhoid bacteria entering the intestine through intestinal villi. There they multiply. It enters the blood vessel. See the blood vessels to the other systems and to the liver, spleen, and again to the bloodstream and alimentary tract. It causes perforation and ulcers. So multi-organ effects from the typhoid fever are, first is the PAS patches in the intestine, in the liver and gallbladder. It affects the spleen, it affects the bone and bone marrow, it affects solid viscera, other solid viscera, even it affects the heart and the major vessels. Clinical features, fever is there. If it is a fever is present, it is acute onset of fever, continuous fever is present, and moderate to high grade of fevers persisting since 6 to 7 days. Classic step ladder pattern not seen in children. Sometimes it may occur, but sometimes we might not be having a step ladder pattern. Classic step ladder fever of typhoid. If we see the down in the x-axis, you can see the day 0, day 7, and day 21. On day 0, we divide according to the incubation phase, invasion phase, status period, and evolution. Incubation phase, firstly it is asymptomatic form and the temperature is also normal. In the invasion phase, that is from the day 0 to day 7, there might be oscillating fever and dissociated pulses are there, headache is there, asthenia, that is weakness, intestinal disturbances are there. And there is a step ladder pattern of fever. The fever might reach up to 104 degrees Fahrenheit. And in the status period, that is from day 7 to day 21 usually. Constant, it is constant typhoid state, diarrhea and splenomegaly might be present. And in the evolution phase, that is from the day 21 onwards, long period of convulsions, even with suitable and early therapy are seen. Other symptoms are myalgias, anorexia, vomiting, diarrhea, constipation, presence of toxic look, which is one of the major contribution by the typhoid fever, and we can see the most common manifestation, toxic look in children, and pain abdomen, headache, and cough. Coming to the clinical examination, we can see a coated tongue from head to toe examination, presence of coated tongue, tympanitis of the abdomen, soft splenomegaly. After 1 week of fever has occurred, we can observe a soft splenomegaly. Hepatomegaly might be present. Chest rhonchi or clefts might be present. Skin rosy spots, that is chest or parambilical region. It is not seen in Indian children. It is in the Western countries. Mild or moderate anemia. Meningismus is present, and jaundice, it is a rare manifestation of typhoid fever. Can anyone tell me one more example causing meningismus in children? Any other example? Even your upper lobe pneumonia will cause meningismus. So it is a viva question. What are the conditions causing meningismus? Typhoid, enteric fever, and upper lobe pneumonia. So coming to the complications of the typhoid fever, CNS, we have an encephalopathy. There might be altered sensorium, convulsions. In toxic cases, we observe seizures, meningism is present, and psychosis. These are all the CNS manifestations. And GIT, already we have discussed about perforation and ulcers. So hemorrhage will occur in 1 to 2%, perforation 0.5%. Perforation in turn or hemorrhage in turn leads to shock or distension of abdomen. There might be peritonitis, hepatitis, and cholangitis. Gallbladders and all, cholangitis might be seen. Respiratory, early forms are bronchitis. Late, when there is dissemination, we have seen the multi-organ involvement. Then you can expect respiratory also. Early is a bronchitis form, and late is the secondary pneumococcal or bronchopneumonia. CVS, myocarditis might be present. Bradycardia is one of the symptoms which we see in enteric fever, and systolic murmur might be present. Skeletal are osteomyelitis and arthritis. Skin, you can see alopecia and furuncles. Renal, UTI in 20 to 25% of cases. Miscellaneous are otitis media, unilateral parotitis, purpuric eruptions, epistaxis, and thrombosis. Diagnosis is mainly clinical. Fever of more than 7 days without any of this below, like toxemia, abdominal pain, or tympanitis, altered sensorium, and mild hepatosplenomegaly might be seen. Investigations. In the first week, you want to go for a blood. Usually, what we see is our blood counts. We send for a routine blood picture, and we also send for a blood culture or blood clot culture. Bone marrow culture, rarely. We usually don't do the bone marrow culture. Unless in second week, you will send a viral test. Viral, it is very good to take after 7 days only. So second week, go for a viral test. But this one is not a specific test. Gold standard for test for typhoid is only blood culture. Third week, stool culture, and fourth week, urine culture. BASU is the form which you have to represent, and agglutination or viral test. Coming to the viral test, agglutins appear in the blood by end of first week, that is the 7th day. O agglutinin, it rises rapidly within 10 to 14 days. Means that if we repeat for a patient with typhoid at the end of 1 week, and we repeat it again after 10 days or 14 days, it will the fourfold increase. The increase in the titer you have to observe. At the end of 7 days and after 2 weeks, you can see a fourfold increase in titer, persistent for months. It might be even persist for a month and disappears in a year. H agglutinin, it rises slowly and persists for years. Hence, O agglutinin is more important in recent infection. So, diagnostic test, how can we diagnose it? If more than 1 per 80 or 1 per 160 or rising titers. See, more than one, interpreting at one time, your rising titer is a very good significant. Rising titer 7 to 10 days apart. H agglutinin indicates past infection or immunization. So O agglutinin is good for measuring the acute forms. False positives and negatives in viral test. False positives immunized with typhoid vaccine, repeated subclinical infections, or any past clinical infection. He might be a healthy carrier of salmonella typhi, and anamnestic response. Patients of cirrhosis and hepatitis also you get a positive viral test. False negatives too early to collect the blood sample. Patient on antibiotic, and 5 to 10% does not respond by antibody formation. If there is no response also, you can get that. So non-specific lab findings in typhoid fever. There are mild pneumochromic anemia, mild thrombocytopenia, leukopenia or leukocytosis might be present. Leukopenia is one of the laboratory investigation which we commonly see, and we think about enteric fever. Eosinopenia, increased ESR, elevated ESR, chronic fever presenting with elevated ESR, we have to keep in mind of enteric fever. Laboratory evidence of mild DIC or hyponatremia and hypokalemias presents, elevation of the liver enzymes, and urine to rule out some proteins and white cells, stool, leukocytes, and blood common. So mild or is a feature of enteric fever. And thrombocytopenia, we have to rule out other conditions also like dengue when patient presented with fever and joint pains, weakness, jaundice, anything you have to rule out. Leukopenia is one of the manifestation of typhoid, and dyspnea also. Increased ESR, you have to rule out your typhoid and also tuberculosis, because both these conditions you have a chronic fever. So you see for any mild DIC is present, see the electrolytes and elevated liver enzymes to rule out hepatitis is present or not, urine to rule out UTI, and also some proteins and white cells might be seen in enteric, and stool leukocytes. Differential diagnosis are infective diarrhea. By the stool examine, you can detect the infective diarrhea we have already discussed. And viral fever, it is self-limiting. Viral fever by the end of 7th day, slowly it self-limits. But enteric fever, it might progress into toxic forms. And UTI, urine analysis you have to do to rule out UTI. Malaria, you have to go for a blood smear examination. And in malaria, you have a high-grade fever with chills and rigors are seen. So, and the presence of hepatosplenomegaly, anemia with hepatosplenomegaly and jaundice. This is suggestive of malaria, but jaundice is rare in enteric fever. Biliary TB, you get a chest X-ray and Montour test also done. Appendicitis, you check for the WBC count. Bacterial endocarditis, it is ruled out in the blood culture. Viral hepatitis, LFTs, Kala-Azar, double rise temperature, good appetite, and no toxemia. Treatment, tepid sponging should be done, paracetamol, adequate water and food intake, hospitalize if any toxic symptoms are seen or complications are seen, you give fluids therapy by IV route. So coming to the treatment of the medical conditions like uncomplicated typhoid fever, you can treat it here. It is fully sensitive, and chloramphenicol or amoxicillin is the first line drug of choice, and fluoroquinolone is the second line drug of choice. Multi-drug resistant typhoid fever, you should go for a fluoroquinolone or cefixime as the first line and azithromycin as the second line. Quinolone, if it is quinolone resistant also, you can go for ceftriaxone, that is third generation cephalosporin, or azithromycin as first line and cefixime in the second line. Coming to the complicated or severe typhoid fever, fully sensitive form, ceftriaxone is the first line and fluoroquinolone is second line. So when we treat them, what are the dosages we want to keep? Chloramphenicol 50 to 75 mg per kg per day for 3 weeks, that is 21 days, at least 2 to 3 weeks. Cefixime 15 to 20 mg per kg per day in 2 divided doses for 7 to 14 days, and ceftriaxone 80 to 100 mg per kg per day IV in 2 divided doses for again 2 weeks, and cefotaxime 100 mg per kg per day in 2 divided doses for 2 weeks. Azithromycin 20 mg per kg per day single dose for 7 days. Ofloxacin or ciprofloxacin 15 mg per kg per day for 10 to 14 days, and gefloxacin 10 mg per kg per day for 7 days. So mostly we give for at least 2 weeks except azithromycin and gefloxacin. Azithromycin you should use only for 1 week. So coming to the treatment of complications, the complications mainly are intestinal hemorrhage. If there is an intestinal hemorrhage, bed rest, food and rice. Don't give NPO, anything orally. NPO, keep the patient on NPO. Give blood transfusions and subcutaneous morphine if needed. In encephalopathy, give steroid like dexamethasone to reduce the encephalopathy and anticonvulsants. To prevent seizure, pneumonia, increase the antimicrobial spectrum, treat with antibiotic, anemia, blood replacement, intestinal perforation, that is the surgical intervention, that is the most complicated and severe form. You give antibiotics like clindamycin and metronidazole. Prevention by personal hygiene. Encourage safe drinking water and good food habits. Avoid unpasteurized dairy products. Public health measures for good disposal of excreta and ban on sale of contaminated food. Tracing and treatment of carrier is one of the form, and active immunization with vaccine. So carriers, when do you call as a convulsion carrier? Patients who continue to shed the bacilli in feces for 3 weeks to 3 months after cure. So from 21 days to 3 months after cure, you call convulsion carrier. Temporary carrier who shed for 3 months to 1 year. Those you call as temporary carrier. Chronic carrier who shed for more than 1 year, he is a chronic carrier. Healthy carrier or intermittent carrier harbors infection without suffering from the disease. Bacilli present in the gallbladder or kidney. Treatment, prolonged treatment with quinolones or cephalosporins. Sometimes it may require gallbladder removal also. So coming to the active immunization, only one thing present is our typhoid vaccine. So 2 typhoid conjugate vaccines currently available, Tyvar TCV and Pedatype. TCV is the most common form which we see. Pedatype is not yet approved. So first dose you advise at 9 to 12 months of each with at least 4 weeks interval with the MMR vaccine. So typhoid vaccine and MMR vaccine, at least 4 weeks interval must be present. Booster dose at 2 years of age. Booster dose can be either conjugate vaccine or VI polysaccharide vaccine. This is about the immunization also. Those receiving booster polysaccharide vaccine needs revaccination every 3 years. See, if the child is taking conjugate vaccine, it is not needed. If child is receiving polysaccharide, revaccinate for every 3 years. Need for further boosters after conjugate vaccine is not yet determined. This is about the vaccination. So thank you for your patient hearing, and please save your chat.